it's Chandra from Green Tree Chiropractic. So a lot of patients aren't aware that chiropractors actually count as primary healthcare practitioners, which means that aside from the normal low back pain, neck pain, leg pain, the kind of musculoskeletal conditions, we're actually taught a lot of systemic problems, things around the heart or the lungs or the organs in the belly. And we're actually taught how to assess for that because we need to appropriately refer somebody, because sometimes some of the conditions can look somewhat similar. So I get asked sometimes by patients what to expect if I was going to do a cardiovascular exam, and I just thought it might be interesting for you guys to see how one is conducted, and I'll kind of talk you through what I'm doing so that maybe you learn a little something as well. So when I'm working on the cardiovascular screen, one of the most important things to do is always to look at your patient. So things that might indicate that somebody is having an issue with their heart, you could see something called cyanosis, which is where you've actually got a lack of oxygenation into the blood. It's kind of a late finding sometimes, but you might see it around the lips, or you might see discoloration into the fingers and toes. And if you have a problem with circulation into particularly the feet, then you're also going to see often changes to the nail bed. So that kind of yellowing, thick toenail, that's a toenail fungus actually, that's a sign of poor oxygenation. It could be cold sometimes, and you see skin changes where you lose hair on the legs or the skin looks a little bit shiny. Another thing that I would look for is I would be looking for swelling. So if somebody has an issue with the heart as a pump, not pumping as effectively, then a lot of times you might see swelling around the feet and the ankle. When you get that kind of swelling, it's typically bilateral. And what we would look for is something called pitting edema, which is where you can stick your finger into the patient's leg, and when you remove it after a short period of time, you see an indentation remains. And that basically means there's fluid in between the cells. That's called the interstitial tissues. But there could be other types of swelling. You could have a blockage with your lymphatic system, which is part of your immune system, and that could cause one leg typically to start to become swollen, or you could have a deep venous thrombosis, which would be down into the back of the leg, and that would look really angry and red. It looks a lot like you've torn a muscle into the calf, but you see some of the veins become very prominent, and you might see streaking. It looks quite hot. Sometimes you can see issues where people aren't getting good return of blood flow from the feet. So the heart as a pump will pump blood away, but actually blood flow from the feet is because the muscles milk it up. They squeeze the blood flow up. And so what you might see again is a little bit of bilateral swelling, but you also get this kind of brown rash, like freckles around the ankles. So we would look for things like that. Other things we'd look for are the nail beds. So if you see here on my patient, he's got a little bit of a curvature into his nail, and this is called digital clubbing. Now, in the UK, this can be physiological, meaning normal. But if you compare his nail bed with mine, you see mine is completely flat, whereas his has got that curve. If you see a new curvature into the nail bed, then that can mean that, again, there's a problem with blood flow, and so that would be something that you would always want to exclude the big bad. So you would always want to make sure that there wasn't a problem like a cancer into the lungs, or maybe a long-term problem with the heart. But if somebody's always had this kind of curvature, then it probably is just physiological normal for them. So it's really only a problem if it's new. So you would start with all of those kinds of findings, and then what we're going to do is we're going to start by palpating what's called the apical impulse. This is the base of the heart to see how heart is beating. Now, this is the breastbone right here, and it's probably about 2.5 fingers worth. The heart actually sits kind of like a fist, and it kind of pokes out a little bit on that left side, but it's very central in terms of its orientation. So what we would do is we would palpate down to where it should be. So I'm going to start at the sternal notch, and I'm going to palpate down to the 5th intercostal space. Okay, and then I'm going to go up to the midclavicular line, and I use 2 fingers, and what I'm feeling for is the beating of the heart against my hand. And typically it's not a massively strong feeling, but it should be about the size of a 20p coin. And things that might make me concerned is if it was further across than what I was expecting. That means it's lateralized, which might mean that the ventricle is actually enlarged. Or perhaps if I could feel 2 beats, because that might mean the ventricle wasn't evenly contracting. If he was really pushing my hand away, that's called a heave. That means the heart is really contracting quite hard. So those are types of things I would look for. After that, what I would do is I would want to see how big is the heart. This is called percussion. We're looking for something called cardiomegaly, which is a fancy word for saying enlargement of the heart. So Tim, what I'm going to do is I'm just going to tap across your chest, and that's just going to put me over the top of your pectoral tissue here, okay? So again, I'm going to start at the sternal notch. And what I'm going to do is I'm going to count down 1, 2, 3, okay, to the third intercostal space. And the ribs here, they kind of go like a smile up on a diagonal. So it's going to bring me, this is called the anterior axillary line, and I start there. And what I'm doing is I'm just tapping in the intercostal space. And you can hear a difference in the pitch, okay? So I would do the third intercostal space, the fourth intercostal space, and I stop when I can hear it, and then the fifth intercostal space. Okay, and again, that nicely lines up with where I would expect his heart to be, so that's a nice normal finding. After that, what I'm going to do is have a listen to his heart. So I'm going to use my stethoscope here, and I always use a diaphragm because that gives me a nice normal sound. And I'm going to start with what's called the aortic region, and that's going to be the second intercostal space on the right. So I'm just going to come, here's the breastbone, so I'm just coming off and I'm having a little listen. Normal heart sound is basically a lub-dub. So things that I might be listening for, this is the pulmonic region. That's the second intercostal space on the left. I'm now going into the third, the fourth, and the fifth intercostal spaces. That's the tricuspid, that's the valve in between the right upper heart and the right lower heart. And then I go to the mitral, which is on the midclavicular line in the fifth intercostal space, and that's the valve between the left upper heart and the left lower heart, so the atrium and the ventricle. So things that I'm listening for, as I said, I should hear that nice lub-dub. So if somebody was having, for instance, a myocardial infarction, so a heart attack, what you often get is a third heart sound, and they call it a gallop rhythm because the heart essentially starts to beat like that. So that would be a worrying finding. I might hear a friction rub, which sounds like this. It's kind of a harsh grating sound, and it means the sac, the pericardium around the heart, is actually rubbing against the muscle tissue, and that can be caused by virus or just general inflammation. If one of the valves in between the chambers of the heart wasn't closing all the way, that can be like a prolapse, then I would hear regurgitated blood flow. That's where it churns a little bit, and that's called a murmur when you listen to that in the heart. Sometimes the valves don't fully close, and that gives you a snapping sound. That's called a stenosis, where it's like a door that doesn't want to open entirely, so it snaps shut. Sometimes what will happen is in the heart, the atrium, which is the upper aspect, and that's where blood would go into, it doesn't fully contract and it just quivers, and that's called a fibrillation. So with that one, what I would be looking for potentially would be an absence of a first heart sound, because instead of hearing the lub-dub, you're just hearing the dub bit because it's just quivering rather than fully contracting. So this would be where I would assess the cardio aspect of the screen, but now I'm going to look at the vascular aspect. And basically what that means is that I want to make sure everything is normal with the arteries going up into the neck, the arteries coming down to the arms, and the arteries going down into the feet. So I'm going to start with the carotid artery. So the carotid artery sits just in front of this muscle. This is called your sternocleidomastoid muscle, and it sits just anteriorly to that. So Tim, if it's all right, I'm just going to palpate. Typically, it's easiest to start at the Adam's apple and just kind of work your way around, and I would just feel that beating against my finger. If I couldn't find it, the artery does run all the way around, so I could try to palpate up a little bit higher, but typically right level with that cricocartilage is the best place to palpate them. Then what I would want to do, and when I was palpating, you shouldn't really feel that much, just a nice steady beat, but I could feel something called a thrill, and a thrill indicates regurgitated blood flow, and it feels a little bit like a cat's purr. There's a vibration against your finger, and that would indicate that there was probably an occlusion, like a little fatty plaque in the blood vessel causing it to churn. If you think of rapid rocks creating rapids in a creek, it's that kind of thing. Next, what I'm going to do is I'm going to listen. Again, I'm listening for that regurgitation of blood, and anytime that's away from the heart, that's always called a bruit. So the artery sits right next to the windpipe. So what I'm going to do is I'm going to ask Tim, when I put the stethoscope onto your artery, I need you just to take a half breath and hold it. And that means I don't hear any abnormal sounds. So take a half breath. Okay, and release. Now I'm going to listen with the bell. That listens for deeper sounds. Take that half breath again. And release. And I would obviously repeat that on the other side. After that, what I could do is I could then look at the vascularity into the arms. So what I'm going to do is I'm just going to check your radial pulse, Tim. I'm just going to get you to turn your hands over, both of them for me. So I'm basically coming on the thumb side. There's a little sticky out bone that I use as a landmark. And I'm basically taking my second and third finger and I'm putting it against the patient's pulse. And what I should feel is that it should have a nice strong beat. It should be nice and regular, and they should be synchronous, happening at the same time, because that indicates that blood flow is coming evenly down the arms. So things that I might find instead, I might have a delayed effect, or it might be a little bit what we call thready, which is where it's more difficult to palpate. And that's not always a bad thing. People that are a little hypermobile will often have what you would consider a weaker pulse, but you can still palpate it, it's still even. So that's just normal for them. It's not always a concerning finding. So as long as that's normal, then I would stop there. I could then come down and assess the blood flow into the feet. So coming in, looking at the blood flow in the feet, I'm going to start with something called the pedal pulse, or dorsalis pedis. So what I'm going to get you to do, Tim, is pull your toes back to your nose for me. This is called your hallux extensor tendon. I would follow that around, and basically I'm going into the junction of the foot and the ankle bones. And I should again feel a nice small beat against both of my fingers, and it should be even. This is very light, so it's difficult to palpate, but it should be nice and even and synchronous. If I couldn't feel it here, and this would be typical in an older person, for instance, because they have very small arteries, then what I could do, relax your foot and just let it go back to neutral, is I could come in and I could find the posterior tibial pulse. And basically, when you're doing that one, you would come and just bring the foot out a little bit. You would basically be palpating at the base of the ankle bone, the medial malleolus, and you're just sliding across into that, and you would be palpating for the artery at the back there. If I couldn't find it here, you could check. There are arteries in the back of the knee, that's called the popliteal artery, or even up here kind of in the crease of the hips, you've got something called the femoral artery, but it's very rare that you would ever need to assess that. Most of the time, you would expect to feel the dorsalis pedis and the posterior tibial pulse. And this would be what you'd expect if I was doing a cardiovascular exam. Thank you for listening.